older working class people have to work because they have to make a living, or they work as a bus driver or in a supermarket and so on. So with the current approach, we are protecting low-risk people in the privileged class while we are putting the burden of generating immunity that will eventually protect all of us. That burden is put on the working class, and especially on the urban working class.
I mean, I think there are creative ways that you can use the welfare schemes that we have in our respective countries to allow this to happen. Instead, what we've done is we have said everyone take a sabbatical. You know, everyone, and of course not if you're an essential worker. If you're poor, you still have to work. So everyone rich, take a sabbatical. Everyone poor, you pay for the cost of this disease mitigation by you taking the risk. I think that this is a strategy that in many ways promotes equality, whereas the current strategy promotes inequality. The science and the morality point in the same direction, as does standard public health practice, and we're just calling to return to all of those things.
Our response to this has been very myopic, I suppose. I mean, or blinkered. We've been looking down a single axis on this, and that's been my problem right from the outset. Is that we surely right from the outset should have started thinking about all the damage that could be done and would be done if we simply went about with following this single goal of getting rid of or suppressing this virus.
We've become obsessed with one metric, perhaps.
One metric, one kind of message, one kind of goal, and the language that surrounds it is very sort of bellicose and very directed at the achievement of that goal. And somehow it's sucked everyone in, and it's created this space, a space from which one can, virtue signal madly. If this only gets people to sit up and look around and say, oh my God, 130 million people are going to starve to death as a result of this. Just that one thought I'd like people to keep in their heads.
Dr. Kulldorff?
While everybody can get infected, and many will get infected, the risk of mortality, the risk of death is very, very different across the ages. And it's not like it's twice as high risk. It's not that it's 5 times high risk. It's not that it's 10 times. It's not that it's 100 times. The difference risk between the oldest and the youngest is more than 1,000-fold in terms of mortality. So while everybody can get the disease, everybody can get infected, the risk of mortality is very, very different between the oldest and the youngest, and there's more than 1,000-fold difference in the risk. And that is, in a sense, a weakness of the pandemic. And if you have an enemy, which this pandemic is, we have to utilize that weakness to minimize the death and to minimize the collateral damage to our society.
And a focused protection plan like we're talking about will help change that. It's the responsibility to limit the damage is a communal responsibility, not simply an individual one. And the messaging has been an individual. If you do this, you do that, you're a good person. You're slowing the spread. I think that's a mistake from public health. It's not taking advantage of the weakness the virus actually has. This is the saner approach, the more moral approach, the more scientifically based approach.
So we think it's important to present an alternative way to approach COVID-19. And this is nothing revolutionary, because this is things that people have been saying since the very beginning back in March, but it's often been dismissed. So we were thinking, coming together, 3 scientists from reasonably respectable universities to sign a declaration urging the world to look into a different approach might have a good effect, where we do a better job protecting older people and other high-risk groups, while we let children and younger adults live their lives normally, going to in-person schools and universities, etc.
Are you advocating a herd immunity strategy?
So herd immunity is not a strategy. Herd immunity is a fact about most infectious diseases, the course that they spread through the population. even if we were to have an effective vaccine, we would be relying on herd immunity as the endpoint of this infectious disease epidemic. So it's less of a strategy than a recognition of a biological fact. Our aim is not to say we should just do nothing. In fact, that's, I think, the misconception that people have when they hear the words herd immunity strategy. In fact, it's quite the opposite. As both Dr. Kulldorff and Dr. Gupta have emphasized, our strategy involves protecting the vulnerable. Now, how do we know about that? We've learned a lot about this disease in the 8 months that we've had to live with it. In particular, we've learned what groups are most vulnerable should they become infected for mortality and other severe bad outcomes. We've also learned about groups that are relatively well protected, even should they become infected. Children, for instance, in the United States, more children have died this year from the seasonal flu than have died from COVID-19. Children, and thank God, are relatively protected from COVID-19 infection should they become infected than an older adult, 65 or 70 or higher, who really are in a vulnerable position. Our strategy takes advantage of that that knowledge we've gained about this and proposes concrete ways of addressing the needs of the vulnerable so that they don't become infected, so they don't die from the disease, while at the same time, the people who are suffering from the collateral damage of the lockdown, closed schools, closed businesses, closed universities, depression, suicidal ideation, all that enormous collateral damage when they face very little risk from death from the disease, that has to end. So the premise is not to do something reckless. The premise is to take account, as Dr. Kulldorff said, of all of public health, all of the harms. We care about cancer. We care about mental illness. We care about all these things. We are not simply just bags of germs infecting one another. We're human beings. And we want to take advantage of the new knowledge we've gained, protect the vulnerable, and let people face the risk of the disease who don't actually face a very large risk of mortality if they were to be infected.
So I guess the million-dollar question is how, because even if you accept that people who are in less vulnerable groups should be allowed to go and get infected, or that it may not be dangerous if they do, and I know some people will even have difficulties with that idea, the presumption has been that there is no practical way to shield vulnerable groups whilst allowing the rest of society to get it. You call it, in your declaration, you call it focused protection. And so far, no one seems to have really spelt out how that could work.
Well, first of all, the key thing is that whatever strategy we use, we're going to reach herd immunity. So if we do nothing, then we're going to have some old and some young people getting infected, and we'll have a lot of death. If we protect everybody equally, then we can have some, eventually, it will take longer time, we're sort of stretching it out, but eventually we can have some old people and some young people getting infected, so we'll have many deaths. But if we do a targeted strategy that protects the elderly and other high-risk groups while letting younger people live normal lives, then among those who get infected before we reach herd immunity, there will be fewer old people and more young people, and therefore be fewer deaths. And there are various ways to do this. One is in nursing homes, where we need to use staff that are either already have immunity, or that we do frequent testing, much more frequent than we do now, of both the staff and the visitor, as well as we have less turnover among the staff. For older people in the workforce, 60 years old, they should work from home. So like an older teacher or an older professor, they could teach online or help other teachers with grading and so on. But there's no reason for a teacher in her 30s or his 40s to work from home.
And Dr. Kulldorff, as you're a Swede, how much of this is basically the Swedish model?
So Sweden failed to protect the elderly in Stockholm at the beginning of the epidemic. So that was not a good thing. But Sweden has, as one of the few countries, tried to do an age-targeted strategy. And we can actually see from antibodies data that it has worked. It's not 100% because that's impossible. You cannot protect everybody 100%. But if we look at the antibodies comparing Spain and Sweden, in Spain, older people and working age adults, the level of antibodies is about the same in those two groups. In Sweden, older people, they have only half the amount of the percentage with antibodies among older people is just half compared to the working age people. So there has been some ability in Sweden to sort of differentiate ages. And it can never be done 100%, and we can never eliminate the risk 100%. But if we want to minimize death in the long term rather than the short term, an age-targeted strategy would be appropriate, both for COVID-19 as well as in terms of all the collateral damage that's being done.
I mean, do you think we should be moving to this kind of regime immediately, no matter what we hear about a vaccine?
Yes, I would agree that we should move towards this regime. Obviously, I hope fervently that we do have a vaccine by spring with which to offer further protection to the vulnerable sectors. But in any event, that we will be relying on a combination of vaccination and naturally acquired immunity to provide the level of protection we really want.